My name is Tara. I am the owner of CareCompass, and CareCompass is an insurance company that specializes in Medicare and other senior products. So I am a licensed insurance broker, and I'm an independent broker. So what that means is I help people to navigate the Medicare process and help them choose a plan that fits their needs. But I don't work for a particular insurance company. So I can help navigate based on what your needs are, your individual needs, help you try to find what might be a good fit. And not just with one carrier, but with lots of different insurance carriers. And this is my buddy Truman. I like to call him the Medicare Navigator and my trusty sidekick. So you might see him pop up a little bit throughout the presentation. CareCompass is located in Duncansville. I do have an office. Most of my clients will come and see me in person at that office. You don't have to. We could do Zoom or anything else. Most people like to come and see me in person. I am the trusted partner of Weber Advisors. So when you're driving around, if you haven't noticed yet, there's billboards all over town with Weber Advisors on them. And I am the trusted Medicare partner. So anybody that they have that needs help with Medicare, I am the person that they trust to take care of those clients. Just a quick little disclaimer, this seminar is only for educational purposes. Any examples that I provide are not indicative of any particular plan or insurance carrier. This is just for educational purposes. And so our mission at CareCompass, we want to empower Medicare eligible individuals to make educated and informed decisions about their health care. Our mission is to help you find the best plan to meet your needs, budget, and lifestyle so you can focus on your health, not your insurance. So what we'll cover, we're going to cover a lot. We'll talk about the basics of Medicare. What are the basic parts of Medicare? What are the costs associated with those different parts of Medicare? We'll become more familiar with enrollment periods, and we'll explore the gaps in your Medicare coverage, as well as plan options that can reduce your exposure in those gaps. We'll look at Advantage plans and Medigap plans, and we'll talk about the pros and the cons of each of those options. And then we'll talk a little bit about Part D prescription drug coverage because they have changed in a big way in 2025. So I want to touch on that, how that will affect enrollees. So here are the 4 parts of Medicare. We have Medicare Part A, B, C, and D. And we'll talk about each of these individually a little bit more. So Medicare Part A is often called your hospital coverage. But really, it's actually inpatient coverage. Part A covers inpatient care in a hospital, but it also extends to a skilled nursing facility as well. Some home health care falls under Part A, and hospice care also falls under Part A. Now, Medicare Part B, on the other hand, think of pretty much everything else that's a medical service. So things that are not inpatient. This would be things like preventive services, doctor visits, outpatient services, lab work, physical therapy, ambulance, durable medical equipment. Some home health care also falls under Part B. Now you saw there was also a C and a D, and we're going to get back to those, but I want to set the foundation by talking a little bit more about A and B, because it's really important to have a fundamental understanding of these before we move on. So Part A and B collectively are known as Original Medicare. Has anybody ever heard that term before? Original Medicare. This is what it means. Part A and Part B, when you're talking about them together, is Original Medicare. Okay? So I may say that throughout the presentation. That's what I mean, Part A and Part B together. Now, a lot of people are surprised sometimes to find out that Original Medicare does not cover everything, and we're going to talk about this at length. But some of the things that are not covered with just Medicare Part A and Part B, custodial care. So this would be things that are activities of daily living. So think bathing, dressing, eating, those types of things. Original Medicare does not cover those. It does not cover routine dental, vision, hearing. It does not cover hearing aids or exams for fitting hearing aids. It does not cover cosmetic surgery, acupuncture, most prescription drugs, okay, and also healthcare outside the U.S., except in very rare cases. So fact or fiction, and you can feel free to just yell it out. Medicare costs the same amount for everyone. No, I'm seeing lots of heads going no, and you're correct. You're all correct. It does not cost the same for everyone. Now, for a lot of people, it is the same, okay? Part A, so you'll remember Part A is our inpatient coverage. For most people, if you or a spouse has worked for 40 quarters, which is equivalent basically to 10 years, okay, then you get Part A, your inpatient coverage, premium free. So you don't pay a premium to have Part A as long as you or your spouse has worked for 40 quarters. If you have not worked enough quarters to earn that $0 premium Part A, then you would have an out-of-pocket based on the amount of quarters that you or your spouse has worked. Now, Part B, you'll remember, is our medical coverage. And Part B, there is a standard premium, and this does change yearly. So in 2025, the standard premium is $185. Most people fall into that category. However, if you're a high income earner, you could be subject to what's called IRMA. And IRMA is an increase where your Part B and also your Part D, which we haven't gotten to yet, could be higher than that standard.
Is that a monthly fee, 185?
Yes, monthly. Yep. All right, so now let's move on to Part D. And you'll notice I skipped Part C, but that's okay. We're going to go back to it. All right? I didn't forget. Part D is prescription drug coverage. So when you hear Part D, think drug. Part D helps you save on your prescriptions. There are two ways to get your prescription drug coverage when you enroll in Medicare. That is through a standalone prescription drug plan. And the other way is through a Medicare Advantage plan, where your prescription drug benefit is actually embedded into that Medicare Advantage plan. Those are the only two ways that you can get prescription drug coverage. Okay? So Part D can relate to a standalone drug plan, or it can relate to a Medicare Advantage plan where that prescription drug coverage is built into the plan itself. We'll talk more about that because some of you might be thinking, I have no idea what she's talking about right now, and that's okay. We're gonna talk more about Advantage plans and standalone prescription drug plans. Now, a formulary, I just wanted to touch on this very quickly. A formulary, has anybody heard that word before? Anybody familiar with a formulary? Okay. So a formulary is basically the list of medications that are covered on your plan. So one of the very first things that I check when I have a client that comes in is, okay, what medications are you on? Because that can quickly tell us the plan options that we'll have. We want to make sure that whatever medications you're on are going to be covered under your plan. Both generic and brand name medications will be on a plan formulary. And then the medications themselves are typically categorized by a tier level. So it might be a tier 1 or a 2 or a 3, 4, 5. The lower cost generic medications a lot of times will fall on those lower tiers, like a 1 and a 2. And then as you start to get into 3s, 4s, and 5s, those are going to be more brand name and specialty medications. So I get this all the time. Not all the time, because I don't see a ton of people that aren't on anything. But I do get the question, I don't take anything. Do I still need prescription drug coverage? Do you guys know the answer to that? Yes, because I have it up here, don't I? Yes, because your needs can change. And if you get put on something, you're going to want to have drug coverage. Okay? The other reason that you want to make sure that you have prescription drug coverage is because if you do not enroll into a prescription drug plan when you're first eligible, when you go to enroll down the road, you'll have a late enrollment penalty. So it's always advised that even if you're not on anything, you still have Part D prescription drug coverage. And you can still get your medications elsewhere. You could still use GoodRx. You can't use them both concurrently. You can't use your insurance and GoodRx, but you can use GoodRx if, in some cases, a medication might be cheaper on GoodRx than it is on your medication plan, right? And you can do that. All right, now we get into Medicare Part C. So this is where it gets a little bit funky and tricky, and we're going to talk at length about Medicare Part C. But essentially, Medicare Part C is a type of insurance coverage, okay? And this type of insurance coverage, you can kind of consider it an alternative to original Medicare. So a Medicare Advantage plan has to have at least the same level of coverage as original Medicare. So it has to be at least as good as original Medicare. And it provides all of your Part A and B benefits, with the exception of hospice. So your Part A and your Part B benefits are combined and included in the Medicare Advantage plan, Part C. And many of them will actually provide extras. So what I mean by extras is dental, vision, hearing coverage, and I talked about how prescription drug can be built into a Medicare Advantage plan as well. So we kind of call all of those things these extras that are added into these plans. So a Medicare Advantage plan is a private insurance carrier that's administering your services, that's helping you to pay the cost of your services. When you hear somebody say Part C or you hear somebody say Medicare Advantage, they mean the same thing. So Part C is a Medicare Advantage plan. And a Medicare Advantage plan, again, is a type of insurance through a private insurance carrier. And we'll talk a little bit more about that as we go. So Medicare enrollment. Depending on if you are already enrolled in Social Security will determine if you are automatically enrolled into Medicare or if you need to enroll yourself. So if have been collecting Social Security for more than 4 months and then your 65th birthday comes up, you will automatically be enrolled into Medicare, Part A and Part B. If you are not collecting Social Security, you will not be enrolled, and you actually have to take that step to enroll yourself into Medicare. Now, the enrollment periods, there's lots of them. We're actually only going to focus on 2. We're going to talk about the initial enrollment period, and we'll briefly talk about the annual enrollment period. But there is a general enrollment period, there's a Medicare Advantage open enrollment period, and there's lots and lots of special enrollment periods as well. So let's talk about initial enrollment period, the most important enrollment period. So true or false? False. My initial enrollment period lasts for 3 months. False? No? True. Oh, I hear a mixed number of people here. So that is actually false. It's 7 months. Your initial enrollment period is actually 7 months, and it's the 7 months that surround your 65th birthday. Okay? So if I have, the month of my birthday is April 15th, then my enrollment period is actually January, February, March, April, May, June, July. So it's the 7 months around your 65th birthday. And there is this one little caveat. If your birthday is on the 1st, then the month before is actually what is considered your birthday month for you. Okay, so 7 months, not 3. And so your initial enrollment period, I didn't actually say what it was, I apologize. This is your opportunity to enroll in Medicare, right? It's your opportunity to enroll. So the annual enrollment period then, have you guys seen all of these different advertisements that you get in October, or they start to drive you crazy by December, right? That's because it's the annual enrollment period. And what the annual enrollment period from October 15th to December 7th is it's your opportunity to look at your plan and make a change if you want. Okay? So it is every October 15th to December 7th. Now, this is not really an enrollment period to sign up for Medicare Part A or Part B. This is an enrollment period where you can look at your plan and potentially make changes to your plan if you wish. Okay, so let's talk about the gaps in your coverage. So going back to original Medicare that we talked about earlier, Part A and Part B. When I think about original Medicare, I like to think of it like this. There are gaps in your coverage. So what do I mean by that? If you only had Part A and Part B, and you went to the hospital, you would have to meet a $1,676 deductible before Medicare will cover anything for you. Okay? And in some cases throughout the year, you might have to meet that deductible more than once. So if you go to the hospital, you're discharged, and you go back 6 months later, you have to meet that deductible again. So this could theoretically happen to you more than once. Now, let's say you're in the hospital, and then you're there for fewer than 60 days. Those first 60 days are covered for you under original Medicare. But if you go beyond that, days 61 to 90, you're starting to pay $419 per day when you're in the hospital. Beyond that, you're into what are called your lifetime reserve days. And now you're spending $838 per day that you're in the hospital if you start to dig into those. So let's talk about skilled nursing. Skilled nursing, days 1 through 20, you would be covered under original Medicare. But beyond that, days 21 to 100, you're starting to pay a daily copayment. Now on the medical side, the Part B side, we have a $257 deductible. And the deductible is the amount that needs to be met before original Medicare will help you pay for your services. So once you've met that $257 deductible, now you're paying a 20% co-insurance for every service. So let's say you had a total knee replacement. You meet your deductible of $257, and then you're paying 20% of the cost of that service. Now, the last one on the bottom there is called excess charges, and I have a little asterisk next to that one because excess charges are interesting. In Pennsylvania, they're not actually allowed. But what they are is a doctor or a facility could charge up to 15% above the Medicare rate. So again, in Pennsylvania, these are not allowed, but outside of the state, they theoretically could be charged to you. So those are the 6 gaps in your coverage, or in original Medicare coverage. So let's use an example of Mr. Jones. He's hospitalized. He was admitted for a 5-day stay, and then he was released with no complications or any further treatment. 3 months later, he was readmitted to the hospital for a separate issue. He has a 3-day stay followed by 30 days in a skilled nursing facility. He is discharged, receives some other outpatient services, and meets his Part B deductible. Then he sees a specialist. So Mr. Jones only has original Medicare. And so because of that, now he's out $5,764 because he went to the hospital twice, so he had to meet his deductible because they were several months apart. The first 20 days in the skilled nursing facility, he was covered, but he was there longer than that, so he has to pay that daily copayment for 10 days. Then he had to meet his Part B deductible, and then he went to see a specialist, and he has to pay 20% of the cost of his services, right? So now Mr. Jones is out $5,764, and that's what we want to try to prevent. So we don't want to be like Mr. Jones. We want to reduce our exposure. So let's talk about how we can do that. So fact or fiction, Medicare Supplement is the same as Medigap. No, I'm seeing lots of no's. That is a fact. They are the same thing. Yeah. So Medigaps are often referred to as Medicare Supplements. So if you hear those words, they're entirely interchangeable. Now, for the sake of this presentation, I like to use the word Medigap because we just talked about the gaps in the coverage, right? So I like to use Medigap because I think of Medigap plans as covering a lot of those gaps that we just talked about. So first thing I want to note here, these are our 2 options, Medigap, also known as Medicare Supplement, and Medicare Advantage plans. And we're going to talk about both of those. But you'll notice here in the middle, you must have Part A and Part B. So it does not matter which option you go with, you must be enrolled in Medicare Part A and Part B in order to enroll in either a Medigap or a Medicare Advantage plan. So let's start with Medigap plans. They're administered by private insurance carriers. It only works with original Medicare. And it fills the gaps that are left behind in original Medicare. They are standardized. So there's actually letters associated with Medigap plans. As if we don't have enough letters that we're already talking about, there's more letters, okay? So they are standardized based on their letter name. I like to think of this as a pay up front system, and I'll talk about that in a second. But before I do that, here you're opting to keep original Medicare. And we just talked about original Medicare and how there's those gaps in your coverage, okay? So what happens is you add on a Medigap plan that comes and fills some of those gaps. In this option, you have to, remember we talked about prescription drug, you have to get it somewhere, right? There's 2 ways to get it. In this option, you have to add a standalone prescription drug policy, okay? So we would have essentially original Medicare as our primary payer, then we have our Medigap plan as our secondary insurance. Then we have a separate card for our prescription drug coverage. And then, if we want to add on dental, vision, and hearing, that is also a separate policy. So the pros of this type of coverage is that it's very comprehensive coverage. Okay? It's plugging fully some of those gaps in your coverage, in your original Medicare coverage. It's portable. There's no networks. So remember, you're keeping original Medicare as your primary insurance. So that means that you can go to any doctor in the U.S. that accepts original Medicare. By federal law, they have to then take your Medigap plan. There's no prior authorizations here. Again, original Medicare is your primary. There's no prior authorizations needed on original Medicare. It's a fixed cost, and it's easy to budget, okay? So I was saying how this is kind of a pay up front system. So we're paying a premium to have this type of coverage. But it can be easier for us because we know what we're paying. There's not as many co-payments and co-insurances as there are on option 2, which we'll talk about. It is a lifetime policy, so when you enroll in a Medigap plan, as long as you pay your premium, it doesn't go away. It just keeps rolling over and over and over. And there is some foreign travel coverage on some Medigap plans as well. Now the cons here is that it is expensive. So it's a high monthly premium to have this type of coverage, and that premium can increase as you get older, will increase as you get older. One of the downsides is that you do have to have a standalone prescription drug policy. You have to add that policy on separately. And generally speaking, there's no added extras. There's not really, there's no dental, vision, and hearing. You would have to add that on separately. Some of them will give you a gym membership, but that's pretty much it. There's not really a lot of extra. Think about a Medigap as just covering the gaps in your medical coverage. That's basically what it's doing. So this is an example of the most comprehensive Medigap plan that you can currently have. It's called a Medigap Plan G. And I don't always recommend this. Sometimes I do. It depends on the person, depends on the needs. But I want to show you this because this is the best Medigap coverage you can currently have. It's a Plan G. So you'll notice 5 out of those 6 gaps that we talked about are covered on a Plan G. So what does that mean? That means you have to meet the Part B deductible of $257, and then the rest of the year for your medical services, you're basically covered, right? So you're not taking your wallet out too often, and that's where I said that I think of this as a pay up front system. I'm paying a lot to have it, but it's covering a lot of those gaps. So if Mr. Jones had this type of coverage, he would not be out $5,764. He would be covered for everything, all of the services that he had. I'm going to touch on this really quickly. Medigap open enrollment period. This is an important time because it's a 6-month window when you initially take Medicare Part B. You have a 6-month window where you can enroll in any Medigap plan that you want without any medical questions. Outside of that period, if you wanted to go into a Medigap, you may have to answer underwriting questions, medical questions. Okay? So during that 6-month period, that's really the best time if you're thinking of going this route. It's the best time to do it because they can't ask you any medical questions. They can't ask if you have a heart condition. They can't ask if you smoke. They can't make a determination of if you'll be accepted into that plan because you are in your open enrollment window. Outside of that open enrollment period, you would have to go through underwriting. So now let's look at the other way to reduce our exposure, and I like to call this option 2. This is a Medicare Advantage plan, also known as, anybody? Part C. Well, yes, Part C, okay? Medicare Advantage plans, also known as Part C. So I like to think of this as an alternative to what we just talked about. This is administered by private insurance carriers, and it's funded by the federal government. It operates more like a commercial plan. So if anybody in here, most of you I'm sure at one point or another have been on a group health insurance plan. And you probably have a deductible. And when you go to the doctor, you probably have a copayment. And if you get lab work, you have a copayment. This operates very similar to that. I like to think of it as a big box that combines all of our different medical services. So we have our Part A and our Part B included in this Medicare Advantage plan. Oftentimes, we'll even have our prescription drug coverage built into that plan as well. Now, it is network-based. So in that first option, there were no networks, right? Because original Medicare was our primary. But here, we're essentially having a third-party insurance carrier cover our medical services, okay? So it does introduce a network. I like to think of this more as a pay-as-you-go system for exactly the reason I mentioned. Commercial plan, a group plan, you're paying co-payments and co-insurances as you go. And this is very similar to that. So there's that box I talked about. So you have your hospital coverage, you have your medical coverage, you have embedded prescription drug coverage, and then in a lot of cases, most cases, you're going to get all of these extra benefits. So you'll get dental, vision, and hearing coverage, a gym membership, you may get an over-the-counter allowance. There's lots of added extras that come with a Medicare Advantage plan, and that's why they're becoming increasingly popular with people. So the pros of this side much less expensive than a Medigap plan. So Medicare Advantage plans, we have some really great ones in our area. $0 premium. You don't actually pay to have that plan, but you still get all of the extra benefits, and then the plan is there when you need it. So you may get a plan that you pay a $0 premium for. Usually when I tell people that, they're like, I don't understand. But remember, it's funded by the federal government, these Advantage plans. The federal government is essentially using a third party that they've contracted with, right? So there are plans where you can pay a premium, but that premium is still going to be a good bit less than you would with a Medigap plan. We talked about prescription drug coverage. It's built into a lot of these Medicare Advantage plans. And oftentimes the coverage on that prescription drug is better and cheaper than a standalone prescription drug plan that you would need to add if you had a Medigap plan. We talked about this: dental, vision, hearing, a gym membership, maybe an over-the-counter allowance, maybe a credit card to help pay for your medical co-payments. All of those are some of those added extras that are oftentimes built into these plans. MOOP protection, that stands for maximum out-of-pocket. And so that is basically, in a worst-case scenario, you have something that happens where you're racking up medical bills. What you owe cannot go beyond whatever your maximum out-of-pocket is for the year. You can adjust these plans annually. So remember that annual enrollment period we talked about? You can change these plans. So if your needs change or the plan itself changes, you have the option to adjust that plan as needed. You can also pair this with a hospital indemnity plan. And I'm not going to go too deep into that, but a hospital indemnity plan just helps to cover some of the costs. Like if you went to the hospital and you had a co-payment, or you had an outpatient procedure and you had a co-payment, or you have an ambulance ride, there's going to be a co-payment. A hospital indemnity plan can pair with this to cover those costs in the event that something happens to you and you do have to go to the hospital or you do need an ambulance ride. Now the cons, it's network-based. So again, we're introducing a network here. So now we have HMOs and we have PPOs. There may be some prior authorizations on certain services on HMO plans. It is more of a variable cost than a Medigap plan because we don't know exactly what services you're going to utilize for the year. You may go to the doctor today and they say they want you to have an MRI, right? So it can be a little bit more variable and therefore a little bit harder to budget. There are co-payments and co-insurances associated. And there's no foreign travel coverage, except in very rare cases.
So in other words, it's best to make a very careful decision when you're eligible for the Medigap, and then make sure you make the right one.
Yeah, well, and Medigaps too, if you enroll in a Medigap initially, it's pretty easy to move out of that into an Advantage plan. It can be a little harder to go the other way. There is what's called a trial right, and I'm not going to go into that here because we'll get in the weeds, but it is harder. We'll just say it's harder to go from an Advantage to a Medigap versus a Medigap to an Advantage. Anything else with regard to Medigaps and Advantage?
Yes.
You mentioned that the government contracts with private agencies or private companies
Insurance carriers.
for the Advantage plan. So it's different for everybody because they're taking your Medicare premium and giving it to that
It's one way to look at it. Yeah, it's funded by the federal government. So, and that's actually kind of how I explain it sometimes because people say, well, if I'm on an Advantage plan and I'm not using my original Medicare, that's not my primary insurance, why am I paying the Part B premium? And I tell them, well, the federal government is funding those Medicare Advantage plans. So you're still paying the federal government. They are then helping to fund that third-party insurance carrier. So that's why we still have to pay that Part B premium.
So if you have an IRMA, you're paying, you're getting a lot more, but it's all going to the government or going to that private company. You don't get any of it.
Me personally?
No, me.
Oh.
I don't me to have it.
Yes, exactly. Now, I don't know if it's actually those funds specifically, but the point is it is federally funded, yes.
Yes.
So the Advantage plan, so is there other Advantage plans that you have to pay out of your pocket if you're just collecting Social Security in the whatever?
I'm sorry, so the question is, are there Advantage plans that you have to pay for?
Yes.
There are some, yes. So there's sort of a spectrum. So you have, most insurance carriers will have a couple of $0 plans where you don't pay anything. And then a few maybe in that mid-tier where you're paying 15, 20, 30 bucks a month, and then somewhere you're paying more.
If you're paying out of pocket, does that mean that the plan gives you better
Yes.
thing? Like, okay.
Exactly right. So if you're paying a little bit in premium, your co-payments might be a little bit lower than they would be on a $0 plan. On a $0 plan, you're not paying to have that. So your co-payments probably are going to be a little bit higher. Or your inpatient hospital benefit. If you're paying a little bit in premium, your hospital benefit and some of the other benefits might be a little bit better than they would be on a $0 plan, because you're paying a little bit more, right? So,
Yes.
But once you reach that out of pocket, then you're done.
Correct.
You don't have co-pays, you don't have, because you reach that.
Because you reached that out of pocket.
So it's
Exactly.
still gonna, like, if you would have a major surgery,
Yes.
it's still gonna be paid.
Yes.
You're just now done because you reached.
You're exactly right. Yes, so that protection, that maximum out-of-pocket protection that we talked about, that is the maximum that you pay for that year. So if you do have something catastrophic happen, you are covered once you hit that maximum.
And those vary?
They do vary, yes. So your max, actually back to your question, your MOOP, might be a little bit better on a plan where you're paying a little bit of premium. Anything else? All right. So these are considerations. We kind of hit on some of these a little bit already, I think, but the things that I like to talk to my clients about are, what is the budget? Am I overall healthy? Do I have any chronic conditions? Am I okay paying co-payments and co-insurances? Do I travel, and is portability important to me? What prescriptions am I taking, and are they covered? That's like probably number one thing I check when I first start talking to a client. That's a big one. What doctors do I see? How often do I go? Do I want an HMO, a PPO, or do I not want to have to deal with networks at all? I want to have the freedom to go wherever I want. Do I anticipate upcoming surgery, therapy, durable medical equipment? Will I utilize extra benefits like dental, vision, and hearing, or a Silver Sneakers gym membership? And so these are sort of the exercise, or this is the exercise that I go through when I have a new client. And so who can help me kind of navigate that is somebody like myself, who at no cost can help you think about these questions to try to determine what makes sense for you, because everybody is different. I have people that are married that are on completely different plans. One's on a Medigap and one's on a Medicare Advantage. A lot of people don't realize you can do that, by the way. You can be on something completely different than your spouse. And I have a lot of people that are, not a lot, I have a number of people who are in that position because their needs are totally different. Their prescriptions are totally different, right? That exercise we went through, they're on completely different ends of the spectrum. And so somebody can help you sort of navigate this like an independent broker. Now, fact or fiction, I must enroll in Medicare upon turning 65, even if I'm still working. So I heard Part A. You automatically get it if you're collecting Social Security. Okay? If you're not, you wouldn't be enrolled. You would have to enroll yourself. Okay. So this is fiction. You are not necessarily required to enroll in Medicare if you have group health insurance. There's a couple of things here that are important, though. If you or your spouse have creditable health insurance, we're going to talk about that in a second, and it's through a large group employer, and by large I mean it has more than 20 employees, and whoever has that coverage is currently working, then you can potentially delay Medicare without a late enrollment penalty. Okay, so a couple of things there that are important. You have to have creditable coverage. We'll talk about that. It has to be a large group employer, and you have to be currently employed, or whoever carries that insurance has to be currently employed. No retiree coverage, no COBRA. Okay, it's based on current employment. Now, I did hear something about Part A. So here's the interesting thing about Part A. If you are going to continue to work and you become Medicare eligible, you can pick up Part A. You're not automatically enrolled unless you've been collecting Social Security. But you can enroll in Part A, but you're not required to. Okay? In a lot of cases, it makes sense to enroll in Part A. What I tell my clients is, well, you've earned Part A. You've paid your taxes, right? You've paid into the system. Why not take it? it essentially would act as a secondary hospital insurance. So oftentimes I'll tell people to take Part A, even if they're going to delay Medicare Part B. Okay? Now there is a caveat to that. If you have an HSA through work, you don't want to take Part A. You can't have Part A and an HSA at the same time. That's the only little caveat to that. So more often than not, my clients don't have that HSA, and so I say, okay, let's go ahead and pick up Part A now, and then you can delay Part B until you retire down the road. So let me get back to creditable coverage. So what that means is the prescription component of your group health insurance is equal to or better than Medicare. That is what is deemed creditable coverage. So you'll usually you'll get a notice of creditable coverage through your HR or through the insurance carrier in September. If you don't have one, you can just ask your HR department to point you in the right direction to get that. Okay, but that coverage has to be creditable. So generally, if it's not based on a current job, it's not going to be considered creditable. So things like COBRA or retiree health benefits, the Pennsylvania penny marketplace, all of those things are not considered creditable. So to answer your question, I think it was sort of what's the process of doing all of this, right? When you're trying to navigate, but you know you're going to work for a while. It depends on your individual situation. Okay, so we have to think about, is there an HSA, is there not? Because a health savings account. So if you have a high deductible plan and you have an HSA associated with that you're contributing to, then you wouldn't want to enroll in Part A. But if you don't have a high deductible plan with an HSA, then you can just ignore that. So what we would want to determine is, when are you planning to retire? Should you pick up Part A? Okay. And then what I would do is we would look at what would be the cost based on your needs for you to go on to Medicare versus what you're paying with your group health plan. Because a lot of times those group health plans have pretty high deductibles and then also pretty high co-payments, and you're paying a good premium to have it. So in a lot of cases, it actually makes sense, even if you're going to continue working, to take a look at Medicare. I had 3 individuals. I did a little mini seminar for a group of individuals, all of whom were over 65 and still working. And they thought, well, I just never enrolled because I didn't need to, right? And I'm like, you're right, but you're going to save a lot of money by going on Medicare. It was definitely in their best interest to take a look at Medicare, and all 3 of them have actually decided to move forward with Medicare starting next month. So it would take some comparison between the group health insurance and Medicare.
If you have the HSA, can you drop it if it makes sense to drop that to go on?
You can. There's a couple of different things with HSAs. So you can decide not to continue to contribute. You know, you could still use the funds that are in that. You just can't have an overlap with the two. You can't be enrolled and continue to contribute. HSAs can get a little bit tricky. So I won't, I'm not going to go down that rabbit hole. But if you have any more questions about that specifically, I'm happy to answer them. Okay, let's talk about Inflation Reduction Act, and then we'll get to prescription drug. And so the Inflation Reduction Act is a landmark piece of legislation passed by the U.S. Congress and signed into law in 2022. It makes changes to policy aimed at lowering the costs for Americans. These changes began in 2023, but we saw some really significant ones in 2025. So the changes that we saw, who's heard of the donut hole? Anybody? The donut hole went away, okay? And everybody's like, yes. So the elimination of the donut hole, also known as the coverage gap, that's a big one. And we'll talk a little bit more here in a second. There is a maximum out-of-pocket for medications now. There used to not be. So now when you go and pick up your medications, if you are on more expensive medications, the maximum that you will pay at the pharmacy would be $2,000. Now that doesn't include if you have a premium for your prescription plan, but the maximum you would outlay when you go to the pharmacy would be $2,000. There's a reallocation of the costs in the catastrophic phase. That'll make more sense in a second. And then we also saw this introduction of the Medicare Prescription Payment Plan, also known as MP3. So a lot of stuff related to prescription drug coverage, and that affects the standalone prescription drug plans, as well as the Advantage plans that have the prescription drugs built into them. I know this is scary, but I'm going to walk you through it. So in 2024, this is what prescription drug coverage looked like. There were 4 stages of prescription drug coverage, and this is how it's been historically. So the first stage is your deductible stage, which means you pay a deductible, say the beginning of the year. Then once you meet a certain threshold, you move to the initial coverage stage. Once you've reached that stage, you now pay 25% or a copayment for your medications at the pharmacy. Once you meet another threshold, then you ended up in the donut hole, the coverage gap. And the reason that that's a scary place to be is because you're paying 25% of all of the cost of your medications in there. So this really would hurt people who were on expensive medications. Now, after the coverage gap, once they meet another threshold, once an enrollee meets another threshold, they end up in what's called the catastrophic phase. So if you get in the donut hole, you want to get out and to the catastrophic phase as quickly as possible, because at least when you get to the catastrophic phase, you're done paying for the year. Now, it's on your Part D prescription drug plan, and it's on Medicare. Okay? So that is historically how prescription drug coverage has looked. With all of the changes that we've implemented, though, we now have 3 stages. So you have your deductible stage, and here you're still paying as the enrollee the full cost until you meet your deductible. Then here in the initial coverage stage, you're paying 25% or a copayment, depending on your plan. But then you'll see here in the catastrophic phase, we still as the enrollee don't pay anything. But you'll see a difference in what your prescription drug plan pays versus Medicare. Medicare used to pay cover 80% of the cost, and now Medicare is like, no, we're only going to cover 20% now. So what that means is your prescription drug plans are now paying a lot more of the cost of your medications. So that's what I meant when I said the reallocation of the costs, right? So the big takeaway here, prescription drug plans are paying more of the cost of our medications now. Anybody have any idea what that means for us as enrollees? It's going to cost more, right? For sure. We're going to see higher premiums, and we have in 2025. Much higher premiums. We're seeing deductibles now that maybe weren't there before. So on some medications, certain tiered medications, there might be a deductible now that wouldn't have maybe been there last year. We're seeing fewer plan choices. So prescription drug plans, some of them are leaving the market or they're offering fewer options. Stricter formularies, tier changes. So something that was maybe a tier 3 is now a tier 4. More drug utilization measures. So prior authorizations, step therapy, quantity limits. And then more predictable monthly costs due to the Medicare prescription payment plan. And just quickly to talk about that, the Medicare prescription payment plan, it is optional. You do not need to enroll in that. And it's really only recommended for people who have expensive medications. We're talking they're spending upwards of $600 a month on meds. That's when it's recommended that maybe you can enroll in the prescription drug plan, and then your costs for the year are more evenly split up throughout the year. So that is new. That just started in 2025, that prescription drug plan. You can opt into that. Like I said, it is totally optional, but you would opt in with your prescription drug insurer. So these are the 10 mistakes that I see very often when people are going through this transition. Listening to a family or a friend. And there's no problem with that. But as I've mentioned many times already, everybody's needs are entirely different. So something that works great for your friend may end up not working for you. So just be careful with what you hear about certain plans because everybody's needs are entirely different and individual. Enrolling in Part B when not needed. I've seen this before where people end up picking up Part B and they're still working and now they have a group health insurance and they have Part B, and so that can happen too. Not paying your Part B premiums and having Part B lapse, that's a big headache. Not considering future healthcare needs, just basing everything off of just right now and not thinking ahead to the future. An example of that would be maybe not enrolling in drug coverage because I'm not on any medications, I don't need it. Missing enrollment deadlines and getting late enrollment penalties, not understanding your own needs, not checking networks or doctors to make sure that your physicians, you can continue to go to the physicians that you want to go to, not checking your prescription drug coverage, not reviewing your coverage often enough. I had a client last year that called me. They hadn't looked, I think He was in his late 70s. He hadn't looked at his insurance since he was 65. And I said, well, how did you get on this anyway? He's like, I don't know. My wife just picked it and I enrolled in it and I've been on it ever since. And I'm like, oh my gosh, this plan has changed quite a bit, you know? So that's a big one. And then not seeking guidance. You know, there's no cost to use a Medicare, a Medicare broker. So I will just leave you with a little bit of information. I'll put my contact information up here in a second. If anybody has Facebook and you'd like to give us a follow, I always post lots of helpful tips. You can find me at Care Compass PA on Facebook. And the other thing is that if you enjoyed this seminar and you feel like you got some value out of it, and because I bought you dinner, if you wouldn't mind, tomorrow I will probably email out a link. If you feel so inclined to leave a little feedback on it, I would greatly appreciate it. But of course, no pressure, only if you feel comfortable with that. So I'm going to leave my information up here. And then did everybody get a brochure and a card in case you want to contact me? Okay. So are there any other questions? I know we ended up getting through some of those questions as we went. Yes?
Contemplating retiring in September 30th of 2026.
Okay.
Now, when would you recommend an initial meeting with you to go over all this information?
So it varies by person. I have people that will come in a year early to talk through it. Is that necessary? No, but some people really like to make sure they have all of their ducks in a row. I would say a few months out from retirement.
You would say my initial enrollment period would be 3 months before, which would be June 30th. So
exactly. So we could meet in June. That'd be a good time to do it.
Or before June 30th.
So you're planning on retiring, and that'll run with when you turn 65.
65 on September 27th of 2026.
Okay, gotcha. So you're retiring and in your initial enrollment period at the same time.
I would like to. I'm just it's on blueprints, but things may change.
So I would say a few months out from your 65th. Yeah, June would be a perfect time to get together initially. Now, what I will tell you is, again, most of my clients will come and see me in person. And what I like to do in this first meeting is I go through a lot of what I just did. So you guys are ahead of the game anyway, because we just did a lot of what I would do in a meeting with someone, is go through the Medigap options and Medicare Advantage and really just make sure that my client understands that. Because it's a lot of information, right? I'm leaving you with a lot of information right now. So to have somebody come in and they know nothing about Medicare and I walk them through all of that and then I say, okay, now let's look at all of these different plans. People's heads would explode, I think, if I asked them to do that. Some people it does happen, but for the most part, I like to bring people in once and really get a feel for what their needs are and go through all of this with them so that I understand what they're thinking. And then we schedule another appointment after that where we actually look at individual plans.
Would you go over the information like what I would need to bring to show like my
Exactly.
your taxes and pay
Yeah, so in that first one, and a lot of who I deal with too, I do get a lot of people that are in their initial enrollment period. I also get a lot of people who are coming off of group health plans, but they're past 65. So we have to actually actively enroll them into Medicare. So I help people with that part of it too. So I do probably a little bit more than maybe what someone else would do. I kind of hold your hand throughout all of that. And so that's another reason I like to have that first meeting, is because then we just make sure, hey, these are the documents that you need, and this is exactly what you need to do. So that's how I do it typically, but it doesn't always work out that way. Sometimes it's one meeting, it's real easy, and but I like to do whatever makes people comfortable, and I feel as though it's a lot of information to take in all at once. Like I said, by coming here, you already have learned a lot about it. For somebody that's coming in completely, not knowing anything to my office, it's a lot of information all at one time to try to get all of that done. Anything else? All right, you're free to go. No, thank you so much for coming. I really appreciate it. Please feel free to reach out if you have any questions.